and get ready for a really good discussion. Okay, so we are 7:01. I think people will probably still be joining in, but for those of you that are on, welcome. We are extremely excited about the next hour. This has been long in coming, and we have an extremely phenomenal group of panelists who are going to be talking about this really important topic. So welcome, welcome, welcome. As you're listening, jot down your questions. Toward the end of the session, we will go through our chat and our Q&A boxes and do our best to address everyone's questions and comments with our wonderful panelists. If there are questions that we don't get to at the end, then we will look to find a venue that we can at least try to answer your questions and follow up, because again, this is a really important topic and a really unique opportunity to have all of these wonderful experts in the same virtual room. So essentially where this is coming from, first of all, thank you to the Society for Vascular Nursing and the Association for the Advancement of Wound Care. This is an absolutely perfect marriage with regard to this topic. So there's a lot of research that shows how important it is that we address the multidisciplinary nature of limb salvage. So when we're looking at peripheral artery disease, we're looking at critical limb ischemia, we're looking at lower extremity wounds and ulcerations. The research is there. We know that, right? We need multidisciplinary teams to be taking care of this. And when you look at those teams, the AAWC, the SVN, when we look at wound care and vascular, those are two really, really important teams that come to the table. And of course, the wound care group, oftentimes very multidisciplinary. So when you look at wound and then you add in that vascular perspective, really just the perfect marriage, to be addressing limb salvage and looking at this so that we can optimize our patient outcomes. So without further ado, I do want to introduce our awesome panelists. You have some really wonderful people at your disposal this evening. So starting with Dr. Alisha Oropallo. She hails to us from New York. Welcome, Dr. Oropallo. Dr. Oropallo is the professor of surgery at the Donald and Barbara Zucker School of Medicine at Hofstra University, Northwell. She completed her residency in vascular surgery at Boston University Medical Center, her general surgery residency also in New York. I think you're going to hear this a lot this evening. Dr. Oropallo is a tireless leader, a very strong voice when it comes to fields of wound management, vascular surgery, limb salvage. So just a phenomenal person. She's heavily involved in clinical trials, in research, interested in education. She's on the forefront of the technology that's coming out within our spaces, and is really, really passionate about improving patient outcomes and putting the patient at the center of basically everything that she does. So welcome, Dr. Oropallo. We also have Chris Owen with us tonight. Chris is another tireless and fearless leader within our space, somebody who is also affecting change and influencing others everywhere she goes. She's currently with the MedStar Health Cardiology Associates Vascular Institute. She's an acute care nurse practitioner and an RNFA, a registered nurse first assist, working in vascular surgery. Chris has over 30 years of experience in many different genres and settings within nursing, but especially with regard to the vascular space and the wound space as well. So Chris brings with her a huge breadth of knowledge. She is the past president of the SVN. So again, very strong leader, very important in the field. She's currently a member of SVN, the Society for Vascular Medicine, SVS, AANP, and she is currently serving on the NP and PA clinical practice committee for the SVN. So another wonderful, wonderful resource in Chris. Welcome, Chris. Leslie Green, wave Leslie. Leslie is going to offer an extremely important perspective today. So Leslie is a patient advocacy and director of education at the Hanger Clinic. So she'll bring kind of a whole nother perspective to us tonight. Leslie has profoundly impacted the lives of everyone that she encounters, and tirelessly, there's that word again, navigates the patient experience through change, leading her patients and the people around her to a better place. So again, when I asked a colleague of mine, what word would really capture Leslie, it was basically that tireless leader. She's just out there constantly doing things, educating, making sure that she's on the forefront of the field that she's in. Lastly, but certainly not least, we have Kara Couch. I have had the opportunity to work with Kara over the last, 8 to 10 years. Another phenomenal leader within the wound care space, also with Vascular. Kara is absolutely everywhere. So she is the director of wound services at George Washington Hospital. She is the president-elect for the AAWC. She's the co-chair of the Alliance for Wound Care Stakeholders. She's been an NP in wound care for over 20 years. And again, is just constantly influencing, motivating, and affecting change, the people around her. So welcome to each of you. Before we get started with the questions, I did want to just briefly introduce kind of what we're going to be talking about this evening, and then I'm going to turn it over and use some guided questions to allow these wonderful experts to talk about the field. So essentially, we're talking about limb salvage. When we look at that as an umbrella, we look at that broadly, we're going to kind of center that on peripheral artery disease. So obviously, we know that limb salvage plays into other conditions, right? We know that venous, and there's so many complex factors that tie into that we will talk about. But when we look at peripheral artery disease, there's essentially different subsets of that. So we know that acute limb ischemia is something that's a right now situation. It's a surgical emergency. It's something that we're dealing with right now. What we're going to be talking about more tonight is critical limb threatening ischemia. So this are patients who have peripheral artery disease in the setting of rest pain or tissue loss. Okay, so again, marrying that wound care with the vascular field is really important. That'll be our primary focus tonight. One of the shocking statistics that's out in the literature that kind of spurs me and makes me passionate about what we do is that 51% of critical limb patients actually do not have adequate vascular assessment prior to amputation. So when we look at this and this topic, we know that even as clinicians who are very well educated and very much in love with what we do, as a whole and as a field, we're not doing a good enough job truly diagnosing, recognizing, and treating this condition. So that's kind of where I come from this. And then the other thing that I want to address is we know that with the social determinants of health, amputations are far more common in lower socioeconomic situations and in non-white populations. So again, a really important topic that we need to be addressing and that we will hopefully touch on tonight. I also want to do a very quick selfish plug. For those of you who are not aware and have not heard of, the American Heart Association has launched a national initiative. It is the Peripheral Artery Disease National Action Plan. Have a group of, again, just wonderful, marvelous experts within the field, really working grassroots and working on the ground floors to try to educate clinicians and patients more about how to better diagnose, recognize, and treat peripheral artery disease. So huge shout out to the American Heart Association for having that initiative and making sure that as we do bring this to the forefront, we have the tools and whatnot to do that. Okay, and I see that we have a Lola. We have a dog that has made an appearance. Lola is famous within our spaces. So for those of you who have not met Lola.
My apologies. She wasn't tolerating me sitting at the island anymore.
Lola with her fluorescent collar.
That's right.
I love it.
Through a walk.
Okay. So moving on, I think probably one of the first things that I would like to hear you guys talk about, and this can go to anybody first, is how you feel we are doing, or what strategies you all have noticed with recognizing peripheral arterial disease, recognizing when that's present, looking for critical limb ischemia, and then secondarily talking a little bit about the diagnosis of that. How do you go about first noticing that that could be an issue, and then second, ascertaining that diagnosis? Chris, do you want to start?
I was just getting ready to unmute myself. I guess, whenever I'm kind of in these panels, I sort of like to bring things back to basics because no, we don't really know where everybody is starting from. And so I think it's important just to sort of like go back between arterial and venous disease, and then how that sort of later on down the line may translate into needing an amputation. So it's important to sort of be able to determine whether there's arterial disease or venous disease, and to refer patients for proper studies. So it's essentially ABIs, pulse volume recordings, and arterial duplexes and things of that nature, to sort of get that first line data. You know, just because somebody doesn't have a pulse, you know, might not mean that they don't have blood flow. It might mean something's wrong with your fingers, you know, that you didn't feel it. Or if somebody does have a pulse, it doesn't mean that they don't have arterial insufficiency. So sometimes I feel like just our fingers is sort of the first, you know, line basis, but I think it's also important to sort of go another step to get some other data points with, you know, ABIs and arterial duplexes and so forth. And then if you think somebody has a venous wound or something, it's important to make sure that they don't have arterial disease as well. And so it's important to also sort of get your venous studies as well, as far as venous reflux studies, and, you know, rule out DVTs and things of that nature. So generally speaking, for vascular patients, we typically get them from somebody else, whether it's their primary care physician, or we'll get them from podiatry, or, you know, maybe even cardiology. They're oftentimes a referral to us after somebody else has seen them first and recognized that there was, you know, a discrepancy of some sort, and they're seeking other information. So I think it's, you know, kind of important to sort of start at the basics and just recognize that there are other specialists out there to ask questions to, and there are other studies that can give you a little bit more information.
Awesome. So Dr. Oropallo or Kara, what is your first, when you see a patient that you're like, man, this is PAD or this is CLTI, what is your first study, or does that depend on the patient?
I can go first, Alisha, if you want, and then as the vascular surgeon, you might have a different.
No, go ahead, Kara.
The first thing I do is I palpate distal pulses, but then every new patient, I also Doppler distal pulses, because I've been fooled before where I thought that I felt a pulse and I'm not, or I'm feeling a tendon flutter or something like that. So every new patient, unless my hand is literally coming off the top of their foot, I'm going to lay a Doppler probe on them to just see, are there signals or not? I'm not going to quibble over, is it +3? I think that's just dumb. Either you have a pulse or you don't. And if they don't, then I'm going to, and they have some sort of wound that's in a limb-threatening issue, then I'm going to refer urgently to my vascular colleagues. So that's my short and sweet.
Yeah, and I would concur definitely what Kara and Chris mentioned. You know, addressing the macrocirculation is very important, and that's going to be your initial step. You're going to take a look at that patient as a whole, not just looking at the physiological arterial punched out lesion that might be stereotypical or maybe not stereotypical in the patient, but you're going to also assess their history as well as the physical examination. So other clues, like have they had a long smoking history in the past, or what have they had other types of chronic diseases that could also lend itself to peripheral arterial disease like hypertension or hyperlipidemia. And so you want to look at that whole patient, and not only do you want to easily assess their circulation, and when you assess the circulation, you want to look at it from again, a holistic approach. Feel their carotids, not just the distal palpable pulses, but, you know, are they palpable or not, but also feeling the groins. Do they have palpable pulses there? And if you release your finger, just like Kara said, you know, you want to place it back on, try it several times just to make sure you're not feeling your own pulse. Again, feeling the back of the knees as well as the dorsalis pedis and posterior tibialis arteries, which are very important to assess. But even if you don't have any of that type of technology, just an ankle brachial index that you can perform at the bedside, or like Kara mentioned, a Doppler signal can be very helpful to elicit whether the patient has peripheral arterial disease or not.
That's a really good point. And I think, as we talk about this in the wound space, sometimes we hone in so much on the open skin that we forget to look up the legs. So palpating for femoral pulses and, popliteal pulses is really important. So for those like with the diagnostics, that's kind of a clinical assessment among everybody. There's no one universal diagnostic tool aside from clinical assessment. A good thorough history, medication reconciliation will tell us a lot, right? If the patient's on methotrexate, that's going to lead us down a different direction than if they're already on aspirin, statin, Plavix, that's going to lead us to another direction. What would you guys say, as far as getting those diagnostic studies, aside from taking a really good history and physical? What is your take on those diagnostic studies, especially considering different environments like you guys have all mentioned, where you might be in a nursing facility where you don't have access, to the ABI or whatever. Talk more a little bit about kind of that, the actual diagnostic studies and what that looks like.
I guess I'll jump in if unless anybody else wants to say anything. But when we talk about ankle brachial indices, it's just basically placing a blood pressure cuff at the brachial, around the brachial artery, and listening to it with a stethoscope and there's even more modern technology out there. But if you don't have any other means, simplistically speaking, just placing a blood pressure cuff around the arm, as we normally do to take blood pressure readings, and also the leg. And you would anticipate that the leg is going to have higher pressures, and that's going to give you an ankle brachial indice above 0.9. So if you calculate that ratio of the systolic blood pressures, you should have that ratio above 0.9. If you don't, that may indicate some sort of arterial insufficiency. So that gives you a good baseline of, does this patient, answer your question, Karen, have arterial insufficiency? Should I be thinking about additional diagnostic tools or not, even if I'm just at the bedside?
Yeah, I think that's great. That is a very easy thing. And sometimes I think in a lot of different realms that gets overlooked. It does provide some really good information, and it's easily done. So yeah, I agree with that for sure.
And these are just the initial steps. Of course, if you detect, and remember, it's also what Kara and Chris mentioned, and yourself, Karen, earlier, is that it may depend on the type of the patient, right? So if they're diabetic, you may have falsely elevated ABI. So always bear that in mind. So if you're getting an ABI of 2.3, and it's not within the realm of 0.9 to 1.1, and you can't explain that, then maybe you should work them up a little bit further. Something else is going on. But I want to also emphasize, go back to the history again, because often I ask my patients, do you have any difficulty in ambulating? Walking. Can you walk a block? Before you came here with your wound, could you walk, a mile without any problems? So that's when you really get into, if they say no, and it's because of intermittent claudication or claudical, which means to limp, they have difficulty in walking a block without having to rest. You can really hone in on whether they have a significant peripheral arterial disease, even before you start to assess them physically.
Yeah, I usually ask my patients, like, when you left your car to walk to my office, did you have any leg pain? Did you have to take a break? Because it can be quite a distance, and so that usually gives me a clue, and it's a very quick, simple question to ask. Can give you some really good information.
I think in addition to that, generally the patients that I see are coming to me because they have a wound. They're not coming because their skin is intact. And I will triage my level of assessment or referral based on the severity of that wound. As we talk about a patient that's got a critical limb ischemia or like a limb threatening wound, which we know like what that looks like. And they maybe, you know, they don't need hospital admission. I am lucky in that I work in a acute care hospital. You know, I have vascular surgery, you know, very close. Like I am very mindful of the fact that many people don't have a vascular lab right by them, or surgeons and, you know, other colleagues that they can call, interventional cardiologists, what have you, to help get that. But when I will say that when you do have those patients that come in that are in that limb threatening situation, I'm not going to mess around and, you know, and try and get a lot of outpatient testing. I'm going to, you know, get them directly to the surgeon or the interventionalist for their angiogram if it's truly a limb salvage situation. And another clue that you can get from their history is, have they ever had an amputation anywhere else? Do they have toe amps on the other side? Do they have their other leg? Typically, you know, arterial disease, bad PAD is not unilateral. You know, there's some evidence of disease bilaterally, and it may be they've only worked up one side, or, you know, I have a current inpatient that we just bypassed his left lower extremity, but I also know he doesn't have a dorsalis pedis pulse on his right. And so I had a discussion with his family yesterday that, you know, this leg is okay right now because you don't have any open wounds. But if you develop an open wound, this is a different situation, and we can't afford to wait, and we need to, you know, put you up on the level of urgency to get specialist evaluation with your vascular surgeon.
I really like this because you're seeing patients from a different avenue than I typically do. And so the perspective is it's great that we're having this conversation, right? Because by the time you guys are seeing them, they're pretty far along in their disease process. Oftentimes. And, you know, when I'm seeing them, it may be varied. You know, I might be seeing them for carotids and they're telling me, oh, by the way, my legs hurt. And then I kind of go down that path. So I really like how this is working out.
That's really interesting too. I think we take that for granted. And Kara, you brought up a great point. And Dr. Oropallo, you might be similar to me. Like in my environment, our wound clinic and our vascular clinic are across the hallway, and I am both. So the patient will see me for their carotids and the vascular, and then see me for their wound, and, you know, a week for their foot. So talk a little bit more about that. I think how these patients are presenting. So Kara, you mentioned, you know, obviously by the time they're coming to us in the wound care clinic, I don't want to say it's obvious, but, you know, we have more of a clue of what's going on. So Chris or Dr. Oropallo, when these patients come in, how do you kind of differentiate between an early presenter and a later presenter before we've gotten to the point that there's, you know, obvious rest pain or obvious tissue loss? What sorts of things do you ask your patients to elicit that? And Dr. Oropallo, you talked a little bit about that earlier, but, you know, what is it besides that claudication that you guys look for that might cue you into, let's not let these people get to Karen and Kara. Let's keep them away from Leslie and her need to, you know, to do some education.
Yeah, I mean, I think we talked about it, the history and the physical exam, and kind of talking about those key things, right? That, are they a smoker? Were they a smoker? How long did they smoke? Do they have hypertension? Is it controlled or uncontrolled? Is it being managed by someone? Or do they have high cholesterol, and is the same thing, you know, is that being managed appropriately? Do they have diabetes? If they have diabetes, what was their last hemoglobin A1C? To kind of address the things that we know that we can fix and that we can optimize, to hopefully make sure that they don't get to that path where they may have a wound and we're talking about other things. So from Jump Street, that's, you know, kind of the beginning steps or stages of that. You know, sometimes we get patients from podiatry who are coming in or being followed, they're diabetics, and they have a wound, and the podiatrist is checking pulses, and they may be either diminished or absent or what have you, and then they'll send them our way, and then we kind of begin our assessment and so forth, and leading to, you know, potential intervention. You know, we don't intervene on everything, right? We talk to the patient, we ask their symptoms, we determine whether it's intermittent claudication, is it lifestyle limiting claudication, we determine whether they have rest pain or not. And we kind of go through those questions and those algorithms. And then of course we look for tissue loss and the degree of tissue loss and their functionality, and then determine what our, you know, what's going to be our next step. Like, is this somebody that we want to do an angiogram on? Is this somebody that we just want to do a CTA on? Is this someone that we, you know, whatever the scenario is, but you have to gather all that data point first and just kind of look at everything and say, okay, what is the best next step for this person?
I might add to that, Chris, because that was really comprehensive. I would say, emphasizing what you mentioned, pain. So something that we haven't addressed quite in depth just yet, but pain is a really early and late signal of the degree of arterial insufficiency. If you listen to the patient carefully, just like you mentioned, the intermittent claudication then it evolves into disabling claudication. So you ask the patient, you know, you can walk, and they say, yes, I can walk a mile, that's fine. And then my leg starts to hurt, and you go into depth about how it's hurting, but to differentiate that from something neurological. But then as the disease progresses, it also progresses in their symptomatology. So in other words, they'll be complaining of disabling claudication, less than 1 block claudication, where they have to rest and then can walk again. And then it gets to the point where you've now developed rest pain, which is continuous pain that is alleviated with dependency of the leg. So that progression can also give you an answer to which Karen was mentioning before. How do you differentiate between the early phases and the late presenters? The late presenters obviously are a lot of what we see altogether, which are the skin failure, right? At the end of the spectrum is the skin failing at that point. And so, you know, when we revascularize patients, and like you mentioned, Chris, we don't revascularize everybody. There are certain reasons why we would revascularize those patients, and those are at the late stages. And sometimes we can catch them a little bit earlier on if they start to have symptoms, and manage those symptoms earlier on with the medications or other types of therapies. But often we are intervening in patients with either rest pain, disabling claudication, or tissue loss.
Very good. Thank you for that. So Leslie, I think that's, you know, without putting you on the spot, that's a really great opportunity for you as far as like, what are you seeing from your standpoint, from the patient perspective, and, you know, kind of in your world, what do some of these things look like?
Well, what I'm hearing here really bears out what I am seeing in the lives of many patients who have encountered PAD and perhaps partial amputations. What I'm hearing frequently is that they're thankful for not just being told what their risk factors are, but being educated about their role as part of their care team and how they can actively live well, having been through the PAD event and or partial amputation of a toe or a few toes, and how they are actively able to avoid these risks. So I think we've come a long way in hearing what each of you are saying bears that out, that we're no longer just handing a pamphlet to a patient and saying, here are the risk factors, but really entering into that collaborative piece with the patient about what do you need to do? How do you need to live now that you've experienced this so that you avoid these risks? Prior to that, I would say that most patients that I'd encountered 3 or 4 years ago were really aware of heart attack and stroke, but they weren't as aware of the issue of PAD and what that meant to their health. And with partial amputation patients that you've talked about, it really allows me to remind them, go back in, stay vigilant, remember the education points that you've learned on, ask questions based on them, talk about events that you're having, seek that constant monitoring. Don't think that this is just a moment in your life, but get screened as you're talking about your different measurements that you do and the different assessments. really look to find those early symptoms or those early diagnostic pieces that you've talked about and reduce those risk factors and improve your quality of life. I mean, ultimately, what you've done for patients who've been through partial amputation, you've not only saved lives by the measurements that you're talking about, but for those who've had partial amputations, with your education, you're helping save gait. And that's where the quality of life comes in. These two issues go hand in hand. I'm pleased when I hear patients who can tell me, you know, what is PAD, when they can actually name it and not just vaguely speak about what they've been through. It just tells me that the passion that's displayed here in your knowledge and in your techniques, it's being conveyed. You're allowing patients to improve their activity levels, which is your ultimate goal, and their quality of life. And I can't tell you, as a person who sits with people every day who've been through this, how pleased I am to see the advancements in this education. I'm hopeful for the day that we have this early enough that we're not looking at partial amputations. Like, you know, we've talked about limb salvage as one of the topics, that through your measures and the education that we can forestall that or avoid it entirely. So thank you. You are doing a tremendous job of making sure that they know what they've been through and they know what they need to do and that they are an integral part of their care team.
So what strategies do you think, with, you know, maybe Leslie first and then everybody, how can we do better? You know, as clinicians, as educators, what do you hear from patients about, you know, man, I wish that Karen would have, or, you know, if Dr. Oropallo would have just told me? What sort of things do you hear in what we can do better to get that word out?
You know, again, the one thing I'm going to say is you are all actively demystifying what this medical condition is. And when we put it out plainly to a patient, they can't live in the vague notion of what they're experiencing. My personal dream, and I know many of you share this dream, is to do such comprehensive care that early on we're pulling you into the prosthetic consults, that we're not only treating the leg with a device, but that we're partnering with you when it comes to these issues of PAD and how does that affect a prosthetic wearer's experience, and what do we need to know more of when it comes to helping them live with devices, and how do we partner more closely, since we know that 54% of all amputations have either this as an underlying issue or diabetic concerns or a combination. How can we collaborate closely at the onset of these things when we're designing offloading devices? How can we, you know, pair our technologies and do what needs to happen to forestall higher up or further amputations? That's my dream, is the comprehensive care team.
Can I chime in on that, Karen?
Yeah, of course.
So I fully agree with everything you just said, Leslie. And I was really fortunate to be trained by a surgeon who's an expert in diabetic limb salvage. And we really started putting like the pieces of that together, of having the comprehensive care model. After I spent about 10 years there, I went to Walter Reed, which was where we treated a lot of new amputees. I'm not going to harp on amputees. I have a point, I promise. But we had everybody there at the table. So the prosthetists and orthotists were down the hall from me. Physical therapy, occupational therapy were there. Orthopedics was upstairs. Vascular was over there. So I could get everyone to the right place. And I think that especially in the type of patients that we're talking about, a lot of them are very medically fragile. They also might have some socioeconomic issues where they can't get to 1 million appointments at once. So we kind of flipped the model on its head, and we have a limb functionality clinic that we do twice a month with physical medicine and rehab, prosthetists, orthotists, physical therapy, vascular surgery, and wound care. And we're checking all level of patients with amputation, but we're also examining their good leg, their other leg. We're making sure, when's the last time you had vascular studies? Have you had screening studies in the last 6 months? You know, like what is your functionality? Can we get you out of your chair? How is your prosthetic fitting? How is your shoe fitting? Do you need inpatient or outpatient PT? And it's not that hard. I mean, it sounds like a lot of people, but I think if you find the shared passion, and you have some of those people, I mean, we were able to convince our rehab, team that we need, a PT and an OT who are passionate about, gait training and amputee care to come to my clinic 4 hours a month. Like it's a whole interdisciplinary thing. So I think that is one way to shift the thinking, because we do a lot of preventative care in that clinic. It's more so preventative rather than, it's proactive care. That's what I think need to be focusing on, just to all of your points that you were making earlier about really assessing and educating the patient to empower them. They don't want to lose another limb. They don't want to get an ulcer. They need to know that they have to call somebody immediately if they start to have issues or they start to have more pain. So.
That's really good perspective, Karen. I think, again, there's that tireless leadership that you've been successful in doing that. That's an amazing feat and a really, really great idea. Does anybody else have something similar like that? Or Chris, I kind of wonder, like in a vascular clinic that isn't mine, where I'm, drawing in wounds, do you see a lot of wound patients? Do you have that opportunity to have that multidisciplinary collaboration? Or is that kind of unique to certain establishments? I think Karen and I are both in academic institutions, which obviously lends itself a little bit more to that. What are your thoughts or takes on that?
Well, I've kind of been in sort of 3 different styles. The first style was my clinic was in the hospital, and the wound center was also in the hospital. And so that was really easy to kind of do, like you say, Kara, kind of gather everybody together and have everybody on the same team and have access to everyone, and sort of maybe, make appointments more accessible so that people aren't coming to the hospital 12 times a week. They're, coming for their vascular lab studies, they're seeing a vascular doctor, then they're going to the wound center on that same day. So that was one model that I had. The previous model that I had before is our wound clinic essentially was run by a nurse practitioner who was a friend of mine, and I was working with vascular and interventional radiology at the time. And so we started collaborating together to, I was helping her understand vascular stuff, and she was giving me, tidbits on wound stuff. And so she and I were able to kind of collaborate together and help our patients out, make sure they were getting the vascular lab studies they needed and the interventions they needed. And so that was really great. The scenario I'm in now, the surgeons spent, my vascular surgeons spend one day in the wound center. And so they have that collaboration, and they are in a transition period right now, which is really great. Because they have somebody coming on board that is motivated. And so from an advanced practice provider perspective, we're hoping to collaborate with her. So at least the advanced practice providers will be able to collaborate on that level, which I think is kind of an untapped group that I think is very valuable, especially in the wound care space. And so I think there's going to be a lot of opportunity moving forward to kind of build that relationship and that practice up and support each other.
I've been hearing really great responses. I'm really impressed how many of you have just like taken this beyond, like Kara starting at their own initiative clinic, Chris talking about interdisciplinary, and Leslie talking about the constant monitoring that's needed in that relationship between you and the patient. And I think those are so important when you're taking care of challenging patients as ours. But I would also maybe add to that is teaching the staff and teaching others and other healthcare professionals is very important. So as you go on this journey of interdisciplinary training or working with others is also helping them identify patients early on too, because they're going to see that as well. And when we talk about how do you identify patients at early stages or early responses rather than having the point where we're looking at their amputations as a predictive value of whether they're going to get another one or not, At-risk behavior is really important. So when you look at, when you start asking about what type of food they eat, and making sure that they follow up with their primary care physician, when was their last hemoglobin A1C? And looking at those numbers, you can really see the at-risk behavior. You take a blood pressure reading and you see that it's off the roof, and they're not being monitored properly, or they're missing medications. These are all indicators of, that they should be counseled and start the regimen of making sure that they get their ABI taken care of. And you can monitor them certainly every 6 months, but at least minimally a year, once you identify some sort of that they might be at risk for PAD.
So one of the common themes that we're hearing there is just engaging with your patients, really taking the time, which I know is hard in our day and age, but taking the time to look at the meds and, remember that vascular disease does not just happen in one vascular bed. So take a step back. I think, as wound care professionals, especially, but in general, making sure that we are looking at our patients as humans. And that might be how we switch to that preventative stage, that we stop and take a look at their diet. We help them with their smoking. So I think those are some really great points. And Kara, I do, of course, my mind is going wild right now. Like, how did you bill for that? How does everybody bill? How did you get their engagement? How do you get them all in one place? And especially with surgeons, I mean, getting surgeons sometimes to stand still, Dr. Oropallo, and like be in the room, so there's so many questions there. I do, if you will, just very briefly, like touch on that a little bit. If somebody said, you know what, I'm passionate about this. I want the dietitian in the room. I want PT. I want my orthotist. I want my vascular surgeon. So, how does somebody go about that when resources may be limited? Were you cold calling people?
Well, I mean, so we're in a hospital outpatient provider department, an HOPD, which is pretty common for a lot of wound care centers. And there is, again, that question of like, who gets to bill? Some of it has to do with which department are you in? So I am credentialed by vascular surgery, but we have this weird hybrid at GW, but essentially the physiatrist, the PM&R doc, is who runs the visits and does the notes and does the billing. We will sign on and do a wound care note if there's a separate, distinct wound care issue that is going on. So we can do that because we're two different services. They're under physical medicine and rehab. I'm under vascular surgery. Podiatry will do the same sort of thing. In my wound center, we're staffed with advanced practice providers, NPs and PAs and podiatrists, and that's how we do the whole gamut of everything. So we will chime in and see them there. The prosthetist and orthotist bill separately. They're not hospital employees, and they are also seeing their patient, to get their whatever device they need. They can see them and bill that all separately. But the beauty of having them all in one place is that they can get their prescription signed immediately. The physiatrist, whoever's writing the note for whatever device is needed, can really do their dictation like right then and there to make sure that there's not going to be a delay because you're trying to gather all of the data that you need. And we can get the A1C in because you need that for the diabetic shoes and all that sort of stuff. So the physical therapists and occupational therapists that come down do not bill for that clinic. Like I said, we're really fortunate that we have an acute rehab unit and a really robust outpatient rehab center that's part of our medical center, and they see the value in this, and and they also, quite frankly, they get referrals out of that clinic, so they may not bill for that 20 minutes that they saw the patient, but we will give them a referral for the patient to go have inpatient an ARU stay to use their device, or they need outpatient gait training, so they're going to get it on the back end that way. And so that's how you can kind of sell that to the C-suite, that, all the if you have to talk money, the money does shake out okay in the end. And, we've not had trouble with, difficulties. Again, if it like, all of us in vascular surgery, you couldn't have multiple providers doing it the same note in the same day on the same patient. But if you were going to switch it around, you can have different disciplines writing notes on the same patient at the same encounter. Does that make sense?
Yeah, definitely. Yeah. Thank you for clarifying that. That's I think that's great. And that's a great model, even getting two specialties in the room.
Yeah,
We may not
you don't
all
have to have
the
all those
ability
people.
to- yeah.
And we did not have all those people when we started. We started with physiatry. So really, we had a really passionate PM in our doc, and he's like, "We're going to run a limb program." Okay, I was like, "Give me a little bit. I've got to get buy-in here." And then we added in, PT. No, we added in the prosthetist, then we added in PT and OT, and then we added in vascular surgery. So you can. This has been a 5-year evolution. I didn't just go, "Boom, I'm gonna instant clinic," but you get some of the key players there. You get buy-in, you make sure it works, and then you go from there.
Awesome. That's wonderful. So Leslie, I think you kind of touched on this earlier, but with regard to that and what Kara just talked about, how do you find successful ways to get the patient engaged in that? Because I think some of what we're talking about, Kara's talking about professional or clinician engagement. How do we get our patients to do more than, like you said, passive attendance?
Absolutely. Well, and again, it all goes to the root of what each of you are actively doing, because you're pricking that little spark inside of them that says, maybe it's not too late. And because that's ignited, we're able to provide education through different education and wellness communities across the nation. Currently, we're serving over 2,000 individuals who have experienced amputation. And to the audience, I think I need to clarify the reason I keep hitting the education note so hard is I am a former educator and social worker and therapist, but I'm also a bilateral below the knee amputee. So what we've been able to develop and offer to different hospital systems and clinics and providers nationwide are a couple of specific topic-oriented education communities where we're letting individuals who've been through either PAD leading to chronic wounds or chronic wounds from diabetic ulcers or other vascular issues. We have communities available that are forward-oriented and positively framed, bringing in educators of your specialty areas to help continue that education and that awareness. When we take a look at especially the wound population, knowing that greater than 30% of those individuals suffer with a level of mental health issues and depression based on just the chronic nature, or that, to be very simple about it, that lack of quality of life or hopelessness that they may be experiencing because they don't know that there are alternatives to that. So we're able to offer education weekly, and we call on providers such as yourself frequently to be our guest speakers, to continue to bolster that knowledge, to let them connect with other people who are further along the path of living well with these issues, to share personal stories and tips and tricks, and really highlight that these conditions do not have to be the end of quality of life, do not have to end in amputation. And so in the wound communities, the issue is not talking about amputation, although patients will bring it up and it's not swept under the rug, but it's awfully acknowledged and then replaced with, before that point, let's consider these. So to that end, thank you to the providers across the nation who've been willing to answer the call of coming on and talking more in depth about what these are and answering even further questions that come up in between appointments. Education is the key to these storms of life. I mean, they really are that safe point. And you guys are on the forefront. You cause it at the beginning, and we help you carry it forward in those collaborative partnerships.
Well, thank you. We appreciate that and that perspective for sure. So we'll kind of at this point, thank you guys very much. I think we've had some really great discussion. I think focusing again, that holism and prevention and tasking the people that we work with to try to switch that scale a little bit. There are some really good questions in the chat box that we have about 10 minutes. So if we can, I'm going to throw out some of the questions, and if the 3 and 4 of you can just kind of real quick answer them from your standpoint. We'll get to as many of these questions as we can. There are a lot of good questions. Those questions that we can't answer tonight, like I said, we will try to find a good venue that you can still get some input from our panelists. So the first one is about remote patient monitoring. So we've talked a lot about kind of our tried and true methods, but how does remote patient monitoring fit into the care model? Do patients need to come in, or can wound management be done remotely so that some of the patients with the multimorbidity can still frequent regular care without coming in? Do you guys do telemedicine visits? And if so, do you find them to be effective? And is that workflow easy enough?
So we do telehealth visits, and the workflow is very helpful. It is not completely a replacement for seeing the patient, but if it's a patient that you commonly know and have been following, or if you anticipate that the patient will follow up in 2 or 3 weeks and you want to see them in between, like intermittent following, I think remote monitoring is extremely helpful in managing the patient. But you have to have the type of patient that can work with the type of technology that's available for remote monitoring.
I think that was our biggest challenge. I'm personally not a fan of telemed visits because it's getting that flow down can be really difficult. And one thing that we found is that a lot of my patients, you have to train them how to do a telemed visit. And so I found it to only be helpful if there was a really involved family member, or if a visiting nurse was involved, because I just couldn't get a good enough assessment. And I was, getting a lot of like, oh, my camera's pointing at the ceiling and, stuff like that. God bless them. But, so that was tricky, but I do think you're right. If it's a reliable patient that understands how to use the technology, it's great. And it can certainly be very effective. I did not do it for new patients. I just need a physical exam. For a new patient that could have a smoldering infection that you just simply can't pick it up on a tele or remote system. There are plenty of even like wound imaging apps that patients can use where they can send in pictures of their wounds like every week or 2 weeks or things like that. There's a lot of technology there. I personally don't think I cracked the code, but that doesn't mean that other people haven't. So I think that it has a use, but you have to be judicious. So.
Chris, I think you're muted, Chris. Sorry. You're muted.
There we go. Yeah. We do telehealth visits also, but I totally agree with you as far as, needing to have the right patient do that, because looking at the floor, looking at the wall, looking at nothing doesn't really help you get a clear view of what's going on. But yeah, I completely agree with that.
Awesome. Okay. And then just kind of a one-off answer from each of you. What's your one method for motivating your clinical teams, your clinic staffs, whoever it is that you're working with, to try to find the same motivation that we might have for learning about PAD or CLTI? Have you noticed any one strategy or one thing that, tends to pull people out of their shells and want to get them engaged?
I like trying to find something that they like and kind of focus on that. Like for instance, today I had an MA who wants to go to PA school, and she knew that I was taking sutures out of a patient, and she had never been involved in that before. So I was like, okay, come on, let's go. Let's, take a peek at this. She was all excited about it. I think it's just kind of finding something that you can connect with them on, and make it fun, because there's so much of this that is not fun. I am constantly trying to make things fun, and if it involves candy or I don't know, whatever fun socks, whatever it has to be, I'm all about that.
I think one thing that we do is I've worked in clinics before where the information was education was siloed, where the providers would only learn this information over here, the nursing staff over here, and admin like over here. And so I think it's hard to get buy-in and excitement from your team if you don't feel like you have as level a playing field as possible. So one thing that I try to do is make sure that everyone's included, because everyone from my admin staff at the front who's greeting my patient, who can pick up if someone's coming in and they're ill, you know, before they get someone clinical. Like they will come in the back and say, oh, so-and-so does not look right. Can you come, you know, check their blood pressure or check their sugar? You need to have that buy-in, because it's all about the patients. And, you know, at least in the wound clinic patients, they tend to be our patients forever and ever, amen, which is kind of fun. But, you know, you really get involved in their lives, and we want to root for them. We want them to do well, you know, and sometimes it's hard because they don't. But I think if people feel empowered that they can make a difference in the patient's life, that really makes a difference.
I agree. I think that getting the individuals that are working with you involved, engaged, and maybe even, you know, if you're in that mode of just being able to reassign topics of interest, like during a huddle, we might break out and each one of us might talk about a different topic or talk about a patient without the identifiers, but about the patient's condition. And people sense to feel like it's different when it's coming from their shoes or their perspective. And so, and chiming in on what does that mean? What does that mean for the patient's care? So I think getting them engaged in different facets, but also I would say just being thankful, right? I mean, they're there, they're working really hard to help the patients, and sharing that passion is also being humble enough to be thankful that they're there with you and working hard for those patients. So when I thank the people that I work around, I find that they have more of an interest and they're overall appreciative of what they do every day for those patients when they go home.
Awesome, good points. Leslie, do you have anything to add?
You know, I think it's been well said, and to reiterate what's been said just adds to the weight of it. So I'm going to echo that, and I'm going to mention that I'm a storyteller. As a former teacher, I am replete with stories about patients, and I'm constantly pointing out the wins to other people who are taking care of them, that maybe because of the nature of your work. I mean, if we think about it, the time that you put in, the energy that you put in, and like was said, this is not always a nice, neat, tidy field that you are in. When people are taxed by that emotionally, to have somebody else come along and say, did you see that win that you were a part of? And help that ball start rolling. So in the same way that I've heard you say, I am the consummate cheerleader. And yes, in fact, I do have pom-poms that I use on Zooms with people that I work across the nation to help them see. And then I find that they start looking, they look harder. When they notice other people are noticing their engagement with a patient, they start to look harder at the wins and the successes, and they come easier and faster when that happens.
Awesome, wonderful. Okay, so there's a lot of other really, really good questions in here. Like I said, we'll try to answer them. I do want to end with one, because I think we can all kind of take this away, and if we can just quickly kind of list some of the things. So one of the questions in the chat is, what is your go-to for patient education resources? So each of you, if you can just share the places that you tend to send your patients, because we can send ourselves as well. So ready, go on that one, and then we'll close from there.
I go to you guys. I shamelessly come and ask for help. I ask you to participate in the communities. I ask you to bring your knowledge forward. So that's where I go. And thank you for accepting those requests.
I send them to the SVN website to get patient education documents.
Always, of course.
We use a lot of the AAWC brochures. We're sensing a theme here, just about general wound care. And one thing I do, and I would recommend that you do, is Google sometime peripheral arterial disease, Google diabetic foot ulcer, see what the patients are seeing, because the stuff that pops up sometimes is a lot of times paid for by people, and it's not the quality resources that what we want to get in our patients' hands. And a lot of medical literature is written way over their literacy level. So, you know, I think you spend a little time in a rabbit hole and poke around and see, and then you can find some other resources that you feel comfortable steering your patients towards.
Awesome. That's a really good point. Dr. Oropallo, what is your go-to?
I would say it's a couple of go-tos. I would say the ADA, the AHA, the CDC, and the SVS. So a lot of acronyms for just, like Kara mentioned, websites that are reputable, that are in layman's language that people can kind of understand if they need more information than what we're delivering.
Okay, awesome. And I will plug that. I mean, the SVN for the vascular side of things, the SVN and the SVS website and resources have been instrumental, just absolutely, to my learning, you know, and branching off that, the SVN. So I would encourage you guys all to visit both the SVS website, the SVN, as well as the AAWC, the American Heart Association, all very good resources. Please, even if you just Google the AHA PAD National Action Plan, really great places to start. And then, you know, if you guys have any questions, those of you who are on this, I know we're all very passionate. So, you know, I'm happy to give my email and contact information, and I'm sure others are as well, so that if we need to further this, we can do that. So thank you all very, very much. Attendees, I know in a lot of areas in the country, the weather is not good right now. So thank you for sharing your evening with us. We hope you got some really valuable tools and input out of this. To our panelists, thank you guys very much for being here tonight and sharing your awesome wide breadth of perspective and expertise and knowledge. And lastly, you know, thank you to the SVN and the AAWC for taking the commitment and really taking this on. You know, I think this is a great collaboration, and hopefully we can see some other organizations and continue these collaborations, because, you know, we all know that we're better as a team. When we work together, we do better, so we can continue to learn from one another. We have about 10 seconds. Does anybody have any closing thoughts that they want to leave everybody with? Nothing. Okay, thank you guys so much for being
very fun. Thank you.
Karen, thank you for putting this together.
Thank you guys.
job.